It is my privilege to introduce and invite Dr. Bavare. He's a vascular surgeon, and he's going to teach us more about venous disease. Who here has had patients with venous disease? There you go. Excellent. We need to learn.
Thank you, Dr. Shah, Dr. Zoghbi, for this kind invitation to present to all of you about venous diseases. I'm Charudatta Bavare. I'm one of the vascular surgeons in the Department of Cardiovascular Surgery at Methodist. As Dr. Shah said, the end is near. We only have, I think, 3 more hours, you said? Hopefully less than that if I can speed up. So it's like this. Venous diseases in 15 minutes. It's like giving you a 7-course meal combined into a little Wonka gum. The good news is we have some Oompa Loompas waiting outside once your mind is completely swollen up with this information. So I'm going to cram all I know about venous diseases in 15 minutes. And more so than how we do it, I think it's more important to tell you all why we do it. Or we should really look at why we do it. Because looking at endovascular therapies, we have all sorts of things going on, but why we do them is really important. I think we'll do with an introduction, a clinical presentation of how venous disease presents, some anatomical considerations which are really key to the diagnosis, and then the algorithm of treatment. Then we talk a little about acute venous problems and then chronic venous problems. This is a mentor of ours from the American Venous Forum, Dr. Steve Elias. He is a vascular surgeon in New Jersey, extremely animated person. His 100% practice is vein practice. So he's like our guru to tell us exactly when we have problems. So I met him at a meeting. The first thing he said is, vein disease is an incurable disease. So that's the bottom line. You can never cure it. You can slow it down. You can stem it away for a few years, but it's going to come back. And that's the expectation that we have to our patients too, that we'll help you with something, but unless you comply, unless we follow you closely, you're going to keep having some problems. We can simmer them down some. And most of them are clearly unhappy, but then also Bill Gates said that the greatest source of learning is your most unhappy customers. So we probably learn a lot from patients who keep coming back to us with problems, telling us where we failed or telling us how we can do things better for the next person. Vein disease presents usually as 3 stages, as I would think. It's acute, which is pretty dramatic, chronic, which is very annoying, both for you and the patient, and the sequelae, which are really annoying more for you as a caregiver than the patient. But then it's the frustration that you're not able to cure them. Acute venous presentation requires prompt diagnosis and treatment. You cannot let these people walk out of the ER or the office. You have to call in the right people, get them in the hospital. Chronic disease is something that is, like I said, annoying, so it requires early symptom control, because once your symptoms go out of hand, you're circling, not you, but the symptoms are circling the drain. It's just hard to get in front of them. And then the sequelae, like I said, really annoying, because once you come to that point, it's very hard for the patient to come back to normal. They never really come back to normal. They come back to somewhat better than what they were, but that's the frustrating part, is the really annoying part. And remember, symptoms are always worse than signs in chronic disease, not acute disease. Acute disease symptoms probably are worse than, signs are probably worse, but chronic disease symptoms are really worse than signs. So, we have to listen to them, give them a patient hearing. Vein clinics are usually not an hour long, but usually 4 to 5 hours long for about 5 or 6 patients, because they need time. We have to invest time. They present in 2 ways. I classified them as acute and chronic. Acute is more like DVT, which is mild DVT, which we see, there's none of the mill. And then rarely nowadays we see phlegmasia, which is a DVT that is so bad, causing so much pressure on the limb that it stops the arterial inflow coming into the limb because of tissue pressure. And then pulmonary embolism is the sequelae, venous thromboembolism as we all call it. Chronic disease is chronic DVT. It could be varicose veins, venous ulcers, the most common things that we see. And then late stages are post-thrombotic syndrome, where people have been undiagnosed or untreated with bad DVT and now have progressed to this condition. I'm sure everyone's gone over this today. I'm just one more person telling you how we grade evidence. So just remember, 1A is great, and then 5 is useless. But anything around between 1 and 2 is something you should take with a pinch of salt and try and make that into your practice. So acute DVT presents, we have a pointer? Okay, I would just do this. So acute DVT is iliocaval, which is in the iliac vein and the cava. Iliofemoral, which is in the iliac veins and the common femoral vein or even lower, and then femoropopliteal. I kept this the lower end of this cone because this is something we don't intervene on. We just give anticoagulation, and I'll come to that. So that's all the spectrum of lower extremity DVT. You can also get tibial vein DVT, peroneal vein DVT, but those are all smaller veins. We don't really do anything intervention-wise. They all progress to could progress to pulmonary embolism if untreated, if the clot propagates, if the clot breaks off and causes a big PE. As you see, this is a very sexy picture, which is showing a big saddle PE going across. Medical students really salivate on that one. So anatomical considerations of what to look for in a PE. So in venous anatomy, the intervention part is there, up there in the groin and the pelvis. When you have clot there, you need to intervene. And in what way, I'll tell you. One more thing to remember, change in nomenclature. The femoral vein used to be called the superficial femoral vein, now exclusively called the femoral vein. Important on an ultrasound read, because if this vein, which used to be the superficial femoral vein, has a clot, the sonographer would say clot in superficial femoral vein. Someone who's not used to knowing anatomy would say, oh, superficial, as in DVT, go home. Big miss, because that can cause propagation of clot, VTE, et cetera, and then just everything is lost. Anything below that, anything below the femoral vein region, from femoral to tibial region, anticoagulation is all you need. So don't worry if you don't see anything there, or if you see something there. What you don't want to see is clot in the common femoral and the iliac vein, and I'll come to that. So you have common iliac vein, which is up here. This is the vena cava, and the left common iliac vein coming in. This is the internal iliac vein. This is the external iliac vein, and this is the common femoral vein here. The greater saphenous vein comes into the common femoral vein, and then that becomes into the external iliac, et cetera, et cetera. When the clot forms, for example, in the common femoral vein, there's a clot in the common femoral vein. The dynamics are, this clot is going to propagate up to the next branch, because blood's flowing through the internal iliac vein constantly from the pelvis with collateral flow. And this clot is going to go up to there and then stop, because there's vein flow going above and proximal to that. So that's the logic where you see common femoral clot. That's where you think this clot is going up to the internal iliac vein. And that becomes iliofemoral DVT, which requires intervention. So the Doppler will never say iliofemoral DVT. They'll always tell you, because they don't look at the iliac veins unless it's ordered as an abdominal ultrasound. So iliac veins are never almost seen, unless you're a BMI of 12 and they can see everything looking at you. And then you look out. So that's what you look out for. You start looking out for, if the read says clot in the common femoral vein, it could be partial, it could be complete. But once you see clot there, you know that clot's going to go higher up. And that's notable detail not to miss on a simple ultrasound report. That clot is, the common femoral vein is always mentioned as positive clot or negative clot. So keep an eye on that. That's the key. As vascular surgeons, we have our own society. We like to dwell upon our own recommendations, and they're pretty good recommendations. We respect them. So the early thrombus strategy for iliofemoral DVT is where we talk about interventions for DVT. That's one of the interventions we do for DVT. Again, femoropopliteal, femoral vein, popliteal vein, tibial vein. We don't look at clot extraction or thrombolysis or pharmacomechanical strategies. The level of evidence is 2C, I told you. Anything at 5, you just forget it. But 1 and 2, take it with a pinch of salt. But it has shown a good level of evidence. So if you have a first episode of iliofemoral DVT, which is less than 14 days duration, so the onset of symptoms has to be within 2 weeks of presentation. Low risk of bleeding, like if somebody has had a CVA in the last 1 month, absolutely not. If someone has had a total hip replacement yesterday, absolutely not. They have good functional status. If they are in a nursing home on a trach and peg, no. If they have a reasonable life expectancy, somebody with extremely severe heart disease or pulmonary disease or extremely bad peripheral vascular disease, no. But otherwise, early thrombus removal has shown to have benefit for prevention of further complications down the line. It doesn't do anything to the leg at that point except decrease the swelling, but it does a lot preventing complications down the line. Early thrombus removal is also indicated in phlegmasia. Phlegmasia is where, like I said, the venous pressure is so high, the tissue pressure is so high that the arterial inflow is now impeded. So you get acute leg ischemia. It's not a cold leg. It does become cold, but it's not a cold leg, which is arterial insufficiency. It's not pale, it's not pale and with paresthesias, but it's actually pretty warm. It's actually very blue, and then it becomes cold because there is no arterial inflow. And that usually requires either endovascular or actually even open surgical procedures. So again, DVT isolated to the femoropopliteal segment, it's only anticoagulation. Patients undergoing pharmacomechanical thrombolysis, which means through catheters, we do not recommend IVC filters as routine unless they have a very poor cardiopulmonary reserve, because then the next hit will be catastrophic for them. So that's a soft recommendation. It's not a very hardcore recommendation. So again, from the 7-course meal, we have this buffet of devices that we use. We have some that actually break up the clot and suck it out. We have some that actually just chew up the clot and suck it out. We have some that actually stay in the vein and drip in thrombolytics, which is usually what we use is tissue plasminogen activator as a recombinant TPA, and that dwells in overnight. The next day we go in and use other devices to suck the clot out. This is a patient with a left iliac vein DVT, iliofemoral DVT, and the catheter goes from the contralateral side and then dwells in TPA, and then they suck it out, and a pretty good result actually. But if you see, the clot burden is pretty incredible out here. All this white shadowing is all clot, and there's nothing going from below, coming up from below. And then you'll see a relatively good result. And I'll come to that. This is not the end of that result. You have to also make sure they have no outflow issues afterwards. In the upper extremity, the same logic applies, that this is a patient where we say a thoracic outlet syndrome with venous thrombosis. We lyse them, we take out the clot, and then obviously we can unearth some of the problems with the first rib causing a problem there. And then we deal with that afterwards. Once you treat acute DVT with thrombolysis, job's not done there. Usually there is an underlying abnormality, like I said, a first rib pinching something, artery pinching the vein, which is called May-Thurner syndrome, or there is an actual disease in the vein itself causing venous stenosis. Multiple X-ray angles need to be used to optimize the view. Intravenous ultrasound is a great modality we actually employ a lot, because the failure to treat an underlying abnormality and the inability to start flow again is the big problem. That's where these procedures fail. An IVC, which is open, looks pretty open. If you see a vein that is compressed, that looks like a sign. This is all intravenous ultrasound, by the way. If you have a vein that is occluded, you don't see any flow here. And if you have a partially recanalized vein, you see some clot there and there's some flow here. Am I over or? Huh? Okay. Oh God, I told you, it's a big buffet. We're screwing down to a little chewing gum for you. So PE, so I'll go over this quickly. So PE is essentially anticoagulation only, okay? We only do systemic thrombolysis if there is a PE with hypotension. And we do catheter-based or catheter-directed thrombolysis if there is a moderate bleeding risk or a failed systemic thrombolysis where you give IV TPA but doesn't work, then we go to go to catheter-based thrombolysis. Again, bigger buffet of devices. We can break up the clot, suck the clot. It's not easy to get to the pulmonary artery through the groin, but it's doable. It's doable. IVC filters, big controversy, right? When to put filters. So the best evidence actually is down here, where there's no recommendation. This is like a duh recommendation, where if you have recurrent venous thromboembolism on anticoagulation, you need a filter. I mean, that's a given. Unless you have an occluded IVC, that's a different thing. So 1B, pretty strong indication, anticoagulation only for an acute PE who can tolerate anticoagulation. If you have an acute PE with a contraindication or a complication, like someone who's bled recently, surgery 1 day ago, or who has had a bleed previously on warfarin or Xarelto, and then you cannot give them any anticoagulation. Again, the buffet just goes on and on. It's like the Bellagio. So multiple filters, all of them need to come out. So Shakespeare said to be or not to be, we ask to do or not to do, because you have to take them out somehow, somewhere. When you put up IVC filter removal, you get these attorney signs first. That's the sad thing, right? So you don't want to see that in your office. The FDA came up with a decision analysis to remove whether to retrieve IVC filters or not. And then in 2013, the Society for Vascular Surgery actually published this article. So the FDA now recommends removing the IVC filter as soon as protection from PE is no longer needed. So if you can take them out, take them out. If you cannot take them out, send them here. We'll try and take them out. But you got to do something. Filter removal again, like I said, it's the buffet. It just goes on and on. Multiple tricks, multiple techniques. It's not easy for filters lying more than a year because they get ingrained in the wall. Some get displaced. Some go out of the IVC. Open repair sometimes is required. Chronic venous disease is something that, if there was ever a disease with willing doctors, this is the disease. I'm not willing though. I'm just telling you, if there was something, they would look at it. Multiple reasons, multiple problems and frustration. So reflux and obstruction, that's the worst combination you can have. So you have vein reflux in the vein because of leaky valves, and you have an obstruction upstream. So you have leaky valves and you're obstructed. That's a bad combination. Ambulatory venous hypertension, or venous claudication as they call it. You get pain when you walk, and that's because of all the veins getting extremely stretched out. I'm over, am I? I'm over. This is the most important talk, Dr. Shah said.
It is.
Okay, so a brief classification of venous disease is you have telangiectasia, which is just under the skin, varicose veins, you start getting swelling of the leg, you start getting some skin changes, you start getting a lot of skin changes. You get a little ulcer, you get a really bad ulcer. You don't want to come to this stage. And if you have someone with this stage, you want to at least bring them to that stage, from C6 to C5. With obstruction, you want to look at pelvic outflow. You need venograms, you need MRVs or CTVs to look at that. For deep veins, ultrasound is important. Look in the femoral vein, common femoral vein, popliteal vein, etc. For the superficial veins, that's when we look at ablation techniques where we go in with catheters and wires and burn the vein from the inside. The logic is you take out that column of blood in the thigh, and then in the leg, compression is what takes care of the rest of the reflux that's happening there. But essentially, all that has to be treated if they have symptoms. If they don't have symptoms of skin changes, ulcers, or bleeding, typically you can wait with compression and then see how they do. But if you have symptoms of these three, you should intervene endovascularly. A venous ultrasound is not a typical DVT study. Everyone orders a DVT study, but what you need is a reflux study, which actually is a dedicated study looking at the valves in the veins and looking at how blood goes back and forth. Reflux time more than 500 milliseconds is the key. So you need compression. It's like location for real estate. This is compression for chronic venous disease. You gotta compress them. Without compression, all you do is just gonna go down the toilet. And so we do angioplasty and stenting for outflow obstruction. We do surgical bypasses. This is not a very easy operation, not a very durable operation. I'm gonna skip the video. I had a very fancy video of reflux, and you can look it up. It's on YouTube. I looked it up today morning. Another sclerosant where we use sclerosant inside the vein. For perforator veins, we do the same thing. Go localize them with ultrasound, and those are the usual veins which cause problems for recalcitrant ulcers on the legs. So if you don't get those veins, those ulcers may not heal. The end. Summary. So acute DVT or acute venous problems, early diagnosis and prompt referrals to a specialist or some higher level of care. Have a very low threshold for ordering venous ultrasound. If it is acute, and if it is chronic, look at a reflux study. A correct interpretation is the key. Like I said, femoral vein, superficial femoral vein, that has happened before. Now we're pretty much standardized with this I-cable thing. If possible, thrombolysis actually reduces long-term complications with post-thrombotic syndrome. And then anticoagulation alone prolongs vascular insufficiency. So if you have a more proximal clot in the bigger veins, just anticoagulation will not be sufficient. So have a low threshold for sending them towards someone, even if you have a simple DVT. Chronic, like I said, compression, and then you have more compression. Set correct expectations to tell them exactly how long it's going to take. It's going to take a long time. They may not come back to normal. Usually they don't come back to normal. A thorough clinical exam, an ultrasound with a reflux study, identify the etiology and then treat accordingly. Like I said, if you miss something upstream, that's a problem. Continue compression again, and then close post-procedural follow-up, and then ensure compliance to what you're telling them. Because if they quit compression, you're screwed as well. So they said the word impossible was not in Napoleon's dictionary. We should try to let him cure vein disease. All right, well, I thank you for your time.
Thank you, Dr. Bavare. We know whom to call now.